And then
the last group is always
catastrophic
winning.
happen. X-ray technician has done his job. Before
and
we
you have done a winning also, trial of also, decannus also, but in a wrong way. Isn't it? Okay. This time will not be that bad with you. We'll give you something better and probably something easy. Okay.
All right.
So again, this same patient, heart has started improving. You must have heard that. And the lung was deteriorating. Your previous team thought of, managing this, and they thought of many things. They have given some fluid bolus and that, etc. And with that, nothing has helped. Probably slightly they have gone down only. Okay. Now, their duty is over. They are left now. You came on the duty, and you have to see. These are the parameters what you can see in front of you. You have to tell me what will be your next plan of action.
ABG done, sir? Any ABG done?
ABG was done last time. That's what we have not repeated ABG. If you want, I can repeat ABG and tell me.
Lungs are worsening, you said.
Yeah.
Lungs are worsening, you said.
Yeah, lungs.
And the saturation is for right upper limb.
Yeah,
Same thing.
yeah, the saturation is from right upper limb.
First improve oxygen parameters in the ventilator to 100. Saturation is 77 now. Can I get an ABG, sir?
Minus
Okay.
109.
ABG, pH is around 7.31, PO2 is around 48, PCO2 is around 48, and bicarb is around 20.
Okay. Lactates and base excess?
Lactate is around 2.4,
Okay.
base excess is -5.
Hemoglobin?
Not the problem.
Hemoglobin is 9.6.
9.6. Okay.
So
Last
beans are
ACT
fine.
value?
Last it is about 180.
180.
So means are fine.
Patient is worsening.
Perfusion is fine. I
Yeah.
think the problem is with the oxygenation.
We'll check
Already we have increased oxygenation FiO2. Can anyone increase ECMO flow as well? Patient is hypoxic.
ECMO
Any X-ray?
ECMO effort is 100.
ECMO is
Chest X-ray and chest X-ray and ultrasound.
Chest X-ray has to do a big patch on the right side. Ultrasound also shows is considered the consolidation on the right side.
Consolidation. The patient is on any vasopressors? Is on
No.
any vasopressors? Sir? No.
and
not-
echo has improved.
Echo has improved.
So are we
Patient is
converting-
on which antibiotics?
Is on meropenem, targostate.
And
In
what is
color
the
is okay.
sensorium of the patient? Neurological
Yeah,
status?
patient
we
was
still-
fine. Neurological
Patient
was fine.
is desaturating.
Saturation. Patient is
We
can
will
we still,
attempt for
So
few
are the
recruitment
pressures,
maneuvers, no?
These are reflective of the right pressure, sir. The P2, P3 are low.
This is the VA.
P1 is
ECMO.
also negative. So is this calibrated again or?
Just-
No, that's not been calibrated. There's
Okay,
some calibration error
we'll
is there.
ignore this. Sir, can we do a ABG of both the hands right now? Just to make
And
sure
you would
the
want to
patient-
know the saturation also on the other side.
Yeah.
SpO2
Other
low.
side, the saturation is fine.
Yeah, I think the PO2 is on the right radial artery. Is it still low?
Yeah. It's
So
around
that means
46.
there is worsening of the North-South syndrome. So we need to act out immediately, otherwise his brain will get hypoperfused.
Yeah.
So what
We
would you
have
like to do?
So probably all the other measures have been tried by the previous team. So probably the
So-
next step is to go for a
Hybrid.
additional
Hybrid
return
ECMO.
cannula.
Please go ahead.
Till the time we can decrease the native circulation, so we can sedate the patient, make sure there's no tachycardia. all of
Okay.
that, while
Fine.
we are preparing for.
So you try to decrease the requirements.
Native
Okay, and
circulation.
sedate the patient. Very good. Well done. What are things you want? My staff will help.
So I'll,
Ashok, give them whatever they want.
Give a
You get ready for the carotid.
We-
We'll have
So
to.
we have
we
a
know
I'll
take
let
a
her
cannula.
scrub
Yeah.
cannula.
One more vein. Shall we?
So how we are planning to do it?
Yes.
The lungs are bad, so
Oh,
we
yeah,
are
yeah.
planning to go.
Shall we go for recruitment maneuver or shall we
That's
go
right,
for
that's the
VAV?
right point. I think we'll set
Go
just
to
re-
V.
so heart is good.
Heart
I
is
think
good.
hemodynamics are okay. The lungs are not so good.
Worsening?
So two options is either you take off from VV to a VA ECMO to just convert it to VV ECMO.
VV or
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 additional
hybrid
convert to
mode.
VAV ECMO.
Yes.
So I think that's the discussion we need to do.
Or shall we do one procalcitonin and escalate antibiotics
Just
to
one second. So if the LV function is pretty good, sir, on the echo, if it is reasonably good. So I'll just want to change the decision. I think we'll just go for a VV ECMO, not for the VAB.
Okay, so you want to just go for
Yeah.
VVA.
convert to
Convert
VV
to
ECMO,
VV.
yeah.
Fine.
So we'll
How
put
will
in
you do
a
that?
return cannula, isn't it? So
We'll
this
have to
is
have
This is the
This is
the drainage cannula. and
drainage cannula. This is the return cannula.
Yeah.
So we'll keep the drainage here only, and we put in a new return one in the
Jugular.
one.
Yes.
Suppose in between, if a patient deteriorates, we should also have a pressure differentiator so that we can at that time convert VAV.
Yes. I think the heart is reasonably good, and he's
I
not
think
under
we
any
shouldn't take the
vasopressor support.
in cannula out right now. We should keep that in place just for the moment. I mean, we should start
Once
the
the
VV
cannula is
ECMO
in, we
and then
So
disconnect it
we will
there.
change to VAV.
No,
No, we are converting to VV ECMO.
I think one decision, I'm sure everybody
Yeah.
agrees with that,
Yeah,
so we'll go
the
ahead
heart
with
is
the VV.
completely improved, so we'll convert it to VV.
So I'm going to insert a venous cannula.
So are we sure? Don't we need to bridge and see
No,
whether
not required, because heart is pretty good. LV function is good, and the hypoxia is worsening. So if you let it, the
No,
brain will
we have to
recover
put in a venous cannula. That I'm sure.
Yeah.
But are we stopping the VAA part?
Yes.
Would you like to discuss first and then come out with one answer?
Yeah,
rather
so
than
because
Because for totally taking of VA, don't we need to just put in a bridge and see whether the patient circulation is enough to hold it?
if you continue and doing bridge,
Okay.
it keeps on hypoperfusing the brain. So
Sure.
time is in essence here. So probably go on a VV ECMO.
Sure.
Yeah.
I think he's reasonably stable to go on a VV ECMO. It doesn't require a VA ECMO at present.
Sure.
Okay.
Yeah.
I think
So if
let's not waste time. I think we should go ahead with
So
the
two of you can take care of the ventilator and the
Okay.
monitor.
So you want to
Maybe one or two
Ashok,
of you can help him with the drugs.
convert to
And
VV
I'll help him
ECMO.
with the cannula.
Okay. So this is the cannula. Give them the jugular cannula. हाँ लगा देंगे.
So
Yeah. VV कर दो.
So at present we will, once the cannula is in place, then we'll just clamp the arterial cannula here and then give the circuit there. That's it, right?
Shall we keep the backup of any CTVS surgeon because it will bleed like anything?
So
You are
at the
lucky
moment
CTVS
we are,
surgeon is
We are
here
just
only.
clamping it right now. We'll call the surgeon.
yeah, at the moment we just clamp.
Just
Give the
call the
circuit that
CTVS
side.
surgeon so that after removing, immediately he will
Till
take
then
care.
if the vitals are okay. Wait, 1 second. Don't clamp.
Don't
Okay.
worry, this is not.
Okay,
That's
go ahead.
Please go ahead.
Yeah.
Please.
Are we ready there? Okay, clamping. Just give the circuit there. We'll have to have 2 clamps. Yeah. Keep looking at the monitor. Cut करें क्या करें? नहीं ना?
You can disconnect and give it.
No,
Huh?
disconnect from where?
Disconnect and give it.
हाँ वो डिस्कनेक्ट करना यहाँ पे तो कहते ना वो पूरा डिस्कनेक्ट करना है. They don't want to go for VAV. They want to do VV.
कहाँ से निकालूं? वो ब्लीड करेगा. एक कैनुला पे रखना है ना.
बट इसको निकालना जरूरत है क्या? VAV करते हैं क्या प्रॉब्लम है हम लोगों को?
If the heart is improving, no?
Heart is improving, but
Heart is completely
why
improving.
to remove the cannula?
No, cannula is still there.
We don't need to support the heart anymore.
First we'll support the hypoxia part, and then if it holds fine, then we can take the
Connector
arterial
है वहाँ?
cannula out. That is the plan.
Yeah.
Yes.
I think the pressures are well maintained because the heart is functioning good. Again, that's a sign that we have disconnected him off pump.
Correct.
And the pressures are maintained.
Have we done?
VV on.
VV is on, sir.
BP is okay. Saturation's improving.
I think we should also add some vasopressors.
Yeah, just keep it ready. Do not. I think the map is not so low to start the vasopressors. Let the things build up.
And for differential hypoxia, we should give rest to the heart.
Optimize the ventilator settings.
Yeah, FiO2 is 100, PEEP
Yeah.
of 10 now.
Yeah. Maybe increase the
Yes,
beep to
sir.
14.
We'll wait for some time.
Is the
We can
way-
give
Increase
some,
it to 14.
Yes.
Generating tidal volumes of 320, that is
Good.
good enough.
That's reasonably good tidal volumes.
Now the means have gone down.
okay.
Flow,
Okay.
Saturation is slowly picking up, but is going into hypotension.
We can add vasopressors.
We can start a small dose of.
yeah. Shall we repeat
Noradrenaline.
ABG and
Noradrenaline,
see?
please. We'll add noradrenaline, sir. A brief.
Yeah. You want to
Touch
add
bit.
noradrenaline?
Yeah.
Touch of NORAD, yes.
Yeah. Start noradrenaline.
We will repeat ABG. See.
Repeat
Repeat
ABG. pH is 7.28. PO2 is around 50. PSO2 is around 38. And bicarb is around 18.
Lactate, sir.
Can we
Like
increase
test
the flow?
3.4.
Flow maybe
Lactate.
the flow is little less. We would want to increase the flow to around 3.5 liters and see.
Yeah. It's
It's
already
2.5 right now.
Yes.
That will
The lactates have increased a bit. They were
So
earlier
3.4
2.4 now.
only. We can increase the noradrenaline a little bit more.
Okay, now there's tachycardia.
Map.
Wait, there is hypovolemia also.
Yeah.
No,
Urine
P1,
output
P2,
last
P3,
to
all
1
three
hour.
have increased.
Urine output last 1 hour.
Can we check the cannula if it is placed properly? P1, P2, P2, P3 have increased.
P1 is more negative.
P1 is more negative. So
We'll give him some volume also, please.
yeah, we'll
We'll
give
him
volume.
500 ml of crystalloid bolus.
How much you want to give?
500 ml, sir.
Circuit is
500 ml of
Yes.
crystalloid. Okay.
chattering
Color,
now.
Shall we
Circuit is
calibrate and
chattering.
see?
color change is okay.
Circuit is chattering now.
Yeah. The flow is good. Circuit color is good.
But P2 is
P2.
145 and P3 is 138.
Okay, okay.
Yeah, so we'll check
So
the
that's fine.
pre-oxygenator and the post-oxygenator.
So we'll give volume,
But-
sir. We'll give volume.
Differential pressure is so low.
We can't give
Delta
a lot of
pressure
volume
is so
right
low.
now.
Yeah, we can't give. I think 500 ml we have given. Go up on the noradrenaline a bit, sir.
You kept the femoral artery line inside. You want to do something or you want to remove it?
So we have clamped
Tomorrow
it so
can
far.
we-
we-
Once the patient is stable, then we'll remove
Yeah,
it.
so I
We
think
can
we'll
bridge
just-
it with something now,
Yeah.
if it is possible.
So maintain the
VP
femoral
is
canal with
70, 50.
anticoagulation. We don't want to remove it right now because in case if he crashes further, I want the backup femoral canal. If I have
So
to
how
go
much time you want to wait?
Maybe we can bridge it right
At least
now.
1 hour.
Maybe
I
3
think we
to
should
4 hours
go
till
go ahead right now because the systolics are down and the mean
So I
blood
think we
pressure
still
is
have a
just
little
on
bit
the
of
evo.
Are we missing on to
Lactates
something?
are elevating,
is-
hypotension is worsening.
P1 is quite
Wait.
negative. Are we
P1
missing
is
on to
negative,
something?
P2, P3 difference is not so high.
So that means either
How is
there
the
is
echo, sir?
But is
The
there
ABG
chattering,
of
some
P2
chattering
and
going on?
PT.
we will get an echo down.
Circuit is
I mean, let's have a
chattering
discussion.
Yeah.
I think machine is doing okay. The patient requires inotropic support. And I think the vasopressor will either, rather than increasing it, we will support with a VAV. That will be the better decision right now. We will then slowly wean off from that thing.
Yeah, I agree for that. Only thing is, can we just do a echo and see if the heart
Yeah,
is quite
yeah,
okay? or
Ah,
not?
yeah.
If the heart is bad, then probably we'll go on.
Eco is saying EF is around 30
Okay.
and your VTI is around 8 and TDS is around 6.
Okay. So
VTI is less than 10. Better to go to VAV ECMO rather than
we will go back to the VAV.
VAV ECMO.
You want to go back to UAV?
Yes.
Okay.
VAV.
Needs tubing.
Tubings there.
Tubings there.
Yeah, please.
Flush the tubings. We need
a Y in the
Y
return
connect.
side.
and also
You want a Y connector? Give them Y connector. Given? Okay.
You have a clamp.
Yeah.
Some clamps also.
The clamps are there. You can take the clamps if you want more. Here.
Oh,
How will we connect?
So you have a Y connector there.
we will require one more, either cut it in between or we require
This
one
one
more
will
tube.
come
Yeah.
here, right?
Start filling.
First fill.
Auric tube
It's
this is.
fine.
Yeah, start filling.
Auric tube this is. ये
और एक syringe दीजिएगा. Sorry.
auric tube चाहिए ताकि वो उधर connect हो जाए. This Y will connect to this end, so we require this thing.
Okay.
and this will connect to the
This
that
will
limb.
be the
And
single
this will
Somebody
be
can
return.
keep
connected.
watching the vitals also.
This will be the single return.
Mhm.
This will go into the vein and this will go into the
Yes.
artery.
Other way, yeah.
Yeah.
Okay.
This is the way you should plan.
Or either you should
Some saline you can get it.
This will get connected here.
देखो पूरा मग्गी दे दिया.
और एक टब ये ऐसा मिलेगा, ट्यूबिंग मिलेगा सिस्टर, ट्यूबिंग.
Okay.
And once it comes, we'll clamp it off.
So clamp it now.
Clamp it.
So clamp it here also. One second, I'll just put some saline. Yeah.
But I clamp it. No problem.
कनेक्टर भी चाहिए सिस्टर, कनेक्टर भी चाहिए.
दोनों
We
तरफ
have to
कनेक्टर चाहिए.
Cut
इस
over
तरफ,
there
उधर.
and
Connected
insert a
to
wire there.
उधर.
Connected it first.
Sir, we will connect the tubing to both this end.
Oh, we
So we
need
need
a
a return canal.
उधर रखना है ना. नहीं वी कनेक्टर चाहिए क्या? नॉर्मल
Connector इसमें
कनेक्टर से
लगा है।
कनेक्ट कर सकते हैं. वी क्यों चाहिए? ओके उधर एक इधर एक लेके.
oh, we'll have to de-air, right? Further de-air, no?
How we are going to do it? I think
One of this will receive from the vein and one of them will receive from
this and
This
this
And
and
that will
should
go to the
over
This
there.
is smaller.
वो
Correct.
पानी
or
भर दो.
either connect from that end to that end, and this will connect to this tubing.
No.
No, this will go, these two will go to the pump.
This one. So
This is the out cannula. This is the return cannula. One of the return goes here. One of the return goes into the jugular.
yeah, sure, correct.
So this we
And this
again
will
have
be
to
this will get connected to
so
here.
But the tubing is short. The tubing is short.
let's do it now. Let's do it. Ask one more tubing to sister.
We want syringe.
One more tubing and
Take
clamp
syringe.
and clamp. One more tubing and clamp.
What about this? We need not flush it.
So one end here, the other end here, and this one connects to this one.
Yeah, just hold this now.
Clamp it, clamp it.
पानी भरना है.
And it will come out, huh? Clamp it.
क्लैम्प करना.
Yeah.
इधर क्लैम्प कर
Shall I
लीजिए.
clamp?
Yes.
Yes.
Clamped.
Okay, ठीक है. So can we
We'll have to clamp this one also.
एक और एक ट्यूबिंग चाहिए sister.
Let me de-air.
Sorry.
इसको अपन ट्यूबिंग वहाँ पे कनेक्ट करेंगे. कनेक्टर
तो ये आपका ये इसको यहाँ कनेक्ट करना पड़ेगा, राइट?
हाँ.
ये उतना आएगा नहीं. तो what we can do is we can connect this here, and this gets connected to this one. ये इतना आएगा नहीं ना? आएगा? It will not come. Yeah, आ जाएगा.
No,
We need a
it's not
more
good.
length.
होगा
We
more
need
length.
a longer tubing. That
Yeah. So the connector is there. We can make it long. Sister और एक ट्यूबिंग चाहिए यहाँ पे.
और एक ट्यूबिंग सर.
ये निकाल के यहाँ नहीं लगा सकते. यहाँ से डिस्कनेक्ट करके इसको लंबे वाले को यहाँ लगा दो.
लंबे वाले को इधर लगाओ, छोटे वाले को उधर लगा दो.
Yeah,
That will I think
that's
solve the
the problem.
purpose.
You take this one here, put a smaller one. You put
Clamp
a clamp
it.
here.
How?
Just interchange this one. Take it out. Remove this one. Remove that.
निकाल लो.
Remove that. No.
वो निकला.
Take it out.
वो निकालेंगे पर करना पड़ेगा.
Yeah, so just put some water.
Shall I put here?
Keep on pouring.
We have to remove this air
Yeah,
also.
watch. Keep on pouring.
It is leaking.
Put. Connect it here.
प्रेशर डिफरेंस के लिए
इसमें एयर है अभी.
Air है अभी.
That's all. We'll take it out.
इसमें डालो. इसमें पानी डालो. ठीक है.
Keep on pouring. Connect it here.
एक मिनट
Put.
This is the air there. Need to
एयर है
remove
भाई
it.
So
यहाँ पे भी एयर है
पहले वो अपनी सर्किट कंप्लीट करो, इसको निकालने
तो
के
वो वहाँ पे कनेक्ट करना है हमें.
वो ये निकलने के बाद
Yeah.
इधर से इधर
इसको और
कनेक्टर्स
clear
नहीं
करना
है,
पड़ेगा.
वो
return
ये
है,
निकलना
फिर उसके
पड़ेगा.
अंदर जाएगा थोड़ा
हाँ वो
ये एयर निकालना पड़ेगा
कैसे निकलेगा?
No, there is a lot of air here.
अगर एक क्लैंप यहाँ
वो
लगा एयर ऊपर आ जाएगी
पानी में डाल देता हूँ. एक
You want some help?
Okay. This is the
किधर?
नहीं यहाँ
इसको नीचे लेके आओ, ऊपर लेके आओ.
इसको नीचे करेंगे तो ऊपर
और ऊपर लेके आओ.
सॉरी
Yeah,
Sorry,
लेके आओ.
इसको ऊपर करना पड़ेगा ना.
Yeah.
हाँ हाँ.
Bring it down.
और एक क्लैम्प दे दो. वो जब भी बाहर आएगा
Down. Bring it
उसके बाद क्लैम्प कर देंगे.
down. Now pull it up.
Leave it down.
Leave it
down.
saline.
Yeah.
Put some saline.
No. Let the air escape.
Yeah.
Yeah,
Let
it's
the
going
gear
up.
go
It's going up.
Where is
Somebody
it?
look at that connection.
Where
Yeah.
is the syringe? Put it
Yeah.
somewhere. Yeah.
It's okay.
वेट
Connect there.
यहाँ का हुआ
तो इसको क्लैम्प कर देते हैं अपन ना.
What is happening?
So now this will get connected to that, and we have to cut that end.
Correct.
We have to cut that end, na?
I'll need a clamp.
Two clamps, please.
Somebody
Two
increase
clamps.
vasopressor support.
Two clamps and
Inotrope
connector.
support.
Yeah,
BP is
going in
55/40. Increase
Yeah,
NORAD to 1 mic.
We are
1
not
mic per
fast.
kg.
Do you want to increase the inotropes?
Yes, sir.
Then this will get connected in the bigger
How much?
line.
One more clamp.
Right
See.
now,
Already it
how
is
much
0.5
going?
mics, no sir.
Yeah.
Increase to 1 mic.
One
You'll have
max.
to put one clamp there also.
Okay. You have clamped the return cannula? Okay.
No, pressures are
Are
low.
we sure?
Okay, come.
Okay,
We have to
clamp
cut it
return
and
cannula.
join it fastly.
Yeah. Ready?
Are we ready with the connections?
Connectors one.
We have connector,
One
na?
second.
Two connectors we have
We
at
have
both ends.
one more connector we need.
Yeah, we have both the one and one.
We have connected at both
Yeah.
ends.
Yeah,
Should I cut it?
yeah.
So you connect with that and I will connect with this end.
Yeah.
Come.
Okay, can you push some
Yeah.
water, please? Again.
Somebody help with this thing.
Shall I do, ma'am?
Yes.
Somebody help with this
Okay,
thing.
this is connected.
I need
There's some
I
air.
need saline. I need saline over here.
Patient has started to have bradycardia.
I need a saline over here.
Give one dose of adrenaline.
Some more,
is
some
not
more,
down.
some more. Yeah, it's
Sir,
done
this is
here.
not showing on
Can
the
I
monitor.
unclamp? May I unclamp?
Just wait a minute. I need support from here side. I'm not
Yes.
able to clamp it.
There is some air.
Yeah. Where is? Shall I give?
Yeah.
NS?
Just leave it.
Put some saline.
Some saline.
I'm ready to unclamp.
Some
Where?
saline here also.
I'm ready to unclamp.
1 minute.
Saturation has gone down. Saturation is not picking up.
Yeah, be ready for CPR.
CPR.
Already
CPR.
FiO2 is.
Yeah, standing by.
Get ready the crash cart. Monitor is off. Monitor is off.
Yeah, I'm ready to
There is
unclamp.
some more
Please
air.
unclamp.
He wants some more saline.
Here it is, sir.
Some more air here. Need flush, please.
Give it to me, I can do it.
Yeah.
Monitor आया क्या?
Monitor is off.
Okay.
Just check the
Connect-
ECG
Connected,
Check the
ready.
leads.
Yeah.
Some
Check
air
the
has gone
pulse.
again. May I open?
Yeah, open
Yes,
it.
over here.
please.
Pulse is there.
I can't feel.
Start CPR.
Start CPR.
Start CPR.
Q1
CPR.
FT.
Heart rate is there. BP, I'm not. So start CPR.
Adrenaline,
Continue.
Okay, now-
Adrenaline, give one dose of
We-
adrenaline, 1
we
ml.
are unclamping this.
Unclamp.
Yeah, all unclamping done.
Yes.
Do for 2 minutes. Okay.
We have
Rational
to
blood pressure
clamp
more than
the-
to 20, 30.
It will go to the
Okay,
venous
stop
side.
CPR. Check the pulse.
Start clamping the venous side. It will all go into the veins only. We have to clamp some part of the veins.
Yeah.
Yeah, yeah, correct. Maybe
This one.
if we have some clamps, we can
Partially.
Partially
can
clamping
put,
the.
yeah. If we have a Hoffman clamp. Do we have a Hoffman clamp?
Hoffman
Hoffman
clamp.
clamp. We have. Sister
You want
Hoffman
some
clamp.
help or
We want a help, sir.
We want help.
you want
sir.
help? You want to call a friend? Anybody from the audience wants to help them out? Hey, koi? nahi hai.
नहीं वो इसमें आ क्यों ना रहा है लेकिन why is it not coming?
ब्लॉक हो गया वो. ब्लॉक हो गया है.
Oh,
Okay, fine.
we need to flush that.
So we'll end the scenario here. We don't want to put you more in mess now. Okay. We'll end the scenario here. And at the end of the scenario, my staff will tell you how to connect the VAV. Okay, that's for sure. Okay, fine. So now, yeah. So now, can you retrospect what has you have done? What when you came, what was the situation? What you have done? At the end, what was the situation? And what do you think why this has happened? And then we are there to debrief you. Just retrospect yourself. I just put out a few points. When you came, you feel that your heart is better, lung is worsening, and you took a decision of going from VA to VAV. That was your first decision. That is what I heard. Okay. Then you had again a thought in your mind. Then when the heart is improved, why should we go for a VAV, which is a complex mode? And that sounds good. Your argument was fine because it's a complex mode. Why you want to go for it? Why not simple VA to VV? That was your second call. And there was some discussion and some confusion on that. I think there was some contradictory. Some people wanted to VAV, some didn't wanted to go for a VAV, some wanted to go only for VV. Okay. Then finally, eventually, you switch over from VA to VV. But then because there is a hypotension, you again thought that we put it on VAV. Okay. And when you tried to do VAV, you were clueless how to connect. Now, either you may not be knowing that, how to connect it, then the problem is with us because then we have not taught you that. Or you were so confused and so panicked that you could not put your brain into and you could not think about it. Okay, this is what is my interpretation from this scenario. Now I want your interpretation from the scenarios. What do you think? What are tell me one points what you think about so that we can join the chain. Okay.
Since the heart function was pretty good, so we thought the VV ECMO will hold on. And he's reasonably hemodynamically, he was stable, ejection fraction was good. Generally, we think that we can pull through without having a VA ECMO.
Yeah.
But
So
unfortunately, he went into a...
yeah. So now we will discuss on why it has happened. So your logic was heart function is improved. Okay. And you assess the heart function on 2.5 liters of flow. Am I right?
Yes.
So to be very precise, at 2.5 liter of flow, heart function was very good. And you thought that we switch over from VA to VV ECMO, which sounds reasonably good because you don't want to go for a complex ECMO. Am I right? Okay, very good, fine. Okay, what was the other thinking?
Basically, we were not sure when is an appropriate time to switch from VA to VV. That is why all the confusion about using a hybrid mode versus switching to VV. That is why we were having doubts.
Okay.
We
so
didn't have the objective criteria to just take off the
yeah,
VA.
so in your mind, there was no set criteria that when to convert from VA to VV, when to convert from VA to VAV, and what is the benefit versus risk. Okay. Probably because we are not very much confident, retrospectively I'm thinking, because we are not very confident that you will be able to manage VAV, you try to find out a simpler way to go for a VV rather than going to this complex way. Am I right?
Yes.
Okay, that was at the back of the mind, and that's again fairly right. If you are not good at something, you don't want to put your foot in that and get it messed up, and that is what has probably had happened. Because we try to push you in that situation. Okay, you have to go and do VAV, and then you put yourself in that, and then you end up in the problems rather than a much more problem than what you came with. Okay, fine. Yes, then.
So, pre-saturation on the right side was 68 for. Are we early in decision of making? We can tolerate, and we have given some kind of diuretics to decongest.
Your previous batch has already done it. They tried your previous night staff.
Yes.
They have already done that, and they have not succeeded. Definitely, they tried to pull out for their duty, so they were escaped out. Their duty is over now, so they could go away, but then you got escaped. Okay, so. So the basic thing is, I think one thing is that you assess heart function. Second thing, there was no clarity in your mind okay, when to switch over from VA to VV or VA to VAV. Okay, this is two things. Okay, anything else you want? Anything else was there in your mind?
The other reason not to keep the VAV was already heart is getting better. Again, the VA can cause again. The afterload
Differential
will be increased.
hypoxia.
So we thought we'll just go if the heart
Okay,
is better.
so you were worried that if we continue our arterial component,
Yes.
the heart might again get worried because of the afterload. Okay, persistent afterload. Okay. So again, your concern were a genuine concern. I agree. But then we'll discuss, can we sort out all this concern with a better option rather than getting into troubles. Okay. Anything else you had in your mind?
And the hypoxia was too much. We were worried that his brain will suffer more damage if you wait for a longer time.
Yeah. So your worry is that if hypoxia persists, you will get into
Cerebral
a more trouble. Okay, like you can have neurological issues. So probably that has prompted you to act fast and get into a VV rather than a VA, because now you feel that heart does not require any more supports. Okay, fine.
Arterial cannula, how to maintain it if you want to make it. Since the arterial cannula was in situ, we were unaware how to maintain it. Or
How to
whether
keep
we
it
should
maintenance.
remove it.
So again, point is, at the back of your mind, you have that this can trouble me, so you didn't get the arterial canal out. Okay, so something what if I have to describe this in one word is, you all were Abhimanyu. You know how to get into Chakravyu, but you could not come out of the Chakravyu, isn't it? So you know that I might get trouble if I go only for VV. So you just kept the arterial canal out. That was again a good thing that you have kept it inside, but you was not knowing how to maintain that. Okay? You just clamped it, and it will get clotted, and that is what eventually happened, isn't it? The arterial canal was clotted. There was no flow in the artery. Okay. So you maintain arterial cannula, and it got blocked. Okay. What else?
And then finally, when we decided we'll go for VV, we got confused with the circuit attachments.
Okay. So you were probably I feel that I might be wrong, but probably that was the whole scenario, all thing in your mind which pushed you to go for VV, because you were not sure
confident about
how are you going to manage this.
Yes. VAV.
So that has pushed you to go for the VV. So you said rather than going into this trouble, I'll just do a simple work and come out, isn't it? But this could have been sorted out by asking a help from a perfectionist. Isn't it? You could ask that, okay, yes, we require some perfectionists to help us out.
Prompted also many times.
Yeah. And then that could have been sorted it out. Okay, fine. So now you understand. This is that is not the reason to go choose a simpler path which might be risky. Okay, fine. So now I think if you
One more thing which probably troubled us was P1 becoming more negative the moment we changed to VV.
I told you that
Calibration.
Sorry.
Calibration problem.
okay, fine.
When the patient started worsening, then it became more difficult to think logically.
Yeah, so that's the usual cycle, you know. See, in a situation where when you came, it was a quiet environment. Rather, it was a good environment because the heart was recovering. Slightly bad because lung was deteriorating. But if given a choice, all of us prefer that we will manage VV ECMO rather than a VA ECMO. Okay, except Madan. Okay, he doesn't mind managing VA ECMO also because he knows he can manage everything about VA ECMO. I am also scared because I know if I need to vent the LV, I am going to be in trouble. But Madan knows he can vent the LV. So that's with everyone. In fact, if given a choice to me, I also prefer VV rather than going for a VA ECMO. And there are reasons for that. Okay, and probably that is what has happened with you. You thought that VA is going to be difficult, then come out. So situation was much better when you came, but that time also it was difficult for you to think, and then the things has gone wrong, and then because things get more and more complex and complex. Anyway, now I'll not drag into that. So now I will discuss one by one point. Why you failed? The reason is you assess the heart, which is partially relieved. Okay. It was not that you were given a trial of and then, yes, if you would have given a trial of and then lungs would have differentiated, you switch over to it, I would have agreed. If he was on a flow of 1 liter and then you were still switch over to only VV, that would have agreed. But it was without giving a winning and trial of. So what has happened is suddenly you put the heart which was able to take a load of 2.5 liters, you asked him to work double and take care of 5 liters of cardiac flow, and that's why the heart failed. Okay, and that is what happens. So,
in case if we had reduced the flow, the knots would have worsened. That's the reason we didn't ask you to reduce.
Yes. So again, you have a genuine reason that you cannot reduce the flow because it could have worsened the hypoxia. Okay. So that was a genuine reason for that. The answer to that was you could have reduced the flow in the artery and you increase the flow in the vein. That would have taken care of your hypoxia. At the same time, that would have taken care of your winning of VA ECMO. Okay. So if you have planned for a VA ECMO, okay, if the flow was 3 liters or say 3.5, 3 liters, you could have given 2 liters flow in the vein and 1 liter flow in the artery. And you could easily understand that how the heart is behaving. At the same time, when you give 2 liters of flow to the vein, the saturation would have improved, isn't it? So this would have been the easiest way of get out of situations.
So that means reduce the flow if you had gone to VAV.
Yeah.
Yes.
You could have reduced the flow on artery,
Yes.
and you could have increased the flow on the vein. And depending on you could have titrated this. If the pressure is going down, you can go up on the artery flow. If pressure is doing well, you can go up on the venous flow. And you could have managed that. That would have become an easy way to do it. Again, your vein behaves like a bridge here. So you don't have to put a bridge to give a trial of. Okay, just clamp the arterial cannula, let the flow go to the vein. Okay, you will see how the heart is behaving. At 8 minutes, you just release the arterial cannula for 15-20 seconds. Let the arterial cannula get flushed. Okay, so you could have easily given a trial of with a VAV in. You don't require even bridge for that, isn't it? So that could have been an easy solution to that. Okay. Now next question is, there's no clarity. I think I made it partially clear. If you required a flow of 1 liter, okay, or if you are at ideal flow is around 20 ml per kg. Okay. So in adults we consider the ideal flow is at 1 liter. So if you are at 1 liter and heart is functioning well, you can still think of coming off VA ECMO, but not at the flow of 2.5 liters because it is a partially supported heart. Okay. So is that the clarity now?
Yes.
So
Okay.
VA ECMO and VV ECMO are entirely different. VA ECMO is for the heart here. VV ECMO is for the respiratory one. VA ECMO, how we will be in? You not done that here. So when the heart is going to recover, or his heart is good, you don't just clamp and remove it. We have a weaning protocol. We have not done that. So just because you are replacing one mode of ECMO to the other mode doesn't mean that you are supporting. Both are entirely different. That clarity you should have.
The only reason we didn't reduce the flow is because he was already on VV, VA ECMO, so the heart liquid will worsen.
For that, you're not supposed to take the cannula out. You have to find a way how to reduce and take the cannula out. That's what sir is saying.
Better to go for VAV and then reduce the
Yes.
force and check for the heart function.
Yes.
So, in both the way, it's, as sir said, vein is cannulated, so it is acting as a bridge also.
Yes.
So, it will be further guided by swinging out of VA and converting to VV after that VAV.
So no doubts, VV is much safer than a VA. For me also, VV is safer than a VA ECMO because VA has got a lot of complications, but not at the safety of the, not compromise the safety of the patient.
Another thing, when you clamp the arterial cannula, same time your distal lymph perfusion was not happening.
Oh, yes.
Because the connection is after the clamp,
Yes.
right? So that was also another thing.
Right.
And third thing, for converting VV ECMO from VA, you need to take patient in the OT. Means cannula will be pulled out by CVTS surgeon only under the operation theater, right? So that is also going to be complex when you are directly connecting VA to VA.
So in that case, in these situations, when the heart liquid happens, we'll never be able to convert to VV at all, even if the lung is, if the heart is very good.
Yeah.
It is-
Unless
No, not at all. Like first you have to wean the
VAV
VA ECMO.
and
There is no
VAV.
doubt about it. You can just like that pull out the cannula. You have to follow the weaning protocol.
yeah, it's always safe to go from VA to VAV to
Then
VV.
okay.
Now, converting from VAV to VV, let it be only few hours or a day or so. That's fine. But then go a step-wise process because that is going to be more safe, especially when you are assessing the heart with a flow of 2.5 liters. Okay. So when it means almost a 50% support is there. You are not weaned up this heart. If the heart has been weaned off, you are given a trial off and then lungs deteriorates, then the story is totally different. But otherwise, definitely you should not. Okay.
Also, sir has given a clue also. You clamped it and the bleep is falling. No one has seen and like woke up and then corrected back. So it has fallen, you are asking to raise the supports. How long? How much? We have decreased it and to a minimum one. So there you have to stand.
Reducing the, like if we are planning weaning, but at the same time lungs are bad, will that worsen the hypoxia if we don't bridge with VAV?
Yes.
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 That's what sir said.
You have to.
So-
There's no other options. You have to go
Because-
for a VAV.
It's a recovering heart. If
So-
it is going to be more hypoxic,
So when the lungs
it can get hit and blocked.
bad, VAV becomes almost mandatory.
Yeah,
Almost
if-
mandatory.
So of
If
course,
you cannot manage on ventilator.
of course, after managing the non-invasive ways.
Yes.
So like previous batch did. You have tried all those things, it is not improving, you have to do it. There is no shortcuts.
I'll say you are a bit lucky in the sense the arterial canal was blocked and the clot didn't migrate. Okay. Otherwise, the force with which the cannula, the blood is coming from the circuit was around 200 mm of Hg. Okay. So that clot might have been migrated and might have gone somewhere either in the limbs or in the brain or somewhere, and that must have caused systemic emboli and this. And then you would have had it. Okay. So in that way, probably because there was no flow in the cannula, probably that was you were partially lucky. But never keep any cannula unattended. Never keep any cannula unattended. If you want to keep it, you keep it. Usually we don't prefer to keep arterial cannula. We still keep a venous cannula because it is easy to flush. But if at all you are forced to keep arterial cannula, you can still keep it, but you have to keep on flushing with heparinized solution. The way you can do it is you have to just put a pressure bag there, so that because otherwise the blood will not go to arteries, it is going to come back up, isn't it? So you have to put a pressure bag up, and the way you manage your arterial cannula, you have to just continue keep heparin flushed. But again, that you cannot continue for a long time, because eventually that it may not be sufficient. So you might have to get rid of arterial cannula as early as possible. So don't play around arterial cannula. Venous cannula can still do it, but arterial cannula don't play around arterial cannula. You have to be very meticulous. But the moment you stop flow, you have to just try to get the arterial cannula out as fast as possible. Okay, fine. Now my staff will show you how to do it. Meanwhile, you can Ashok, उनको VAV conversion दिखा दें. Meanwhile, if you have any questions, you can ask us.
So because I always thought if the heart is getting better, then if the lungs are bad, we can convert to VV and then, but it's always safer to go for VV and then VAV
Yes,
to
that is always safer. And especially at what support heart is stable.
I know.
That is important.
While in henna, that is going to artery and vein, and disconnect, you connected right, but this will be coming over.
This should be like this.
Like this, yes.
Understood? That's why the flow diverts.
Diverts.
It is connected in
समझा नहीं कैसे?
way is correct, but the character is. Why?
Oh, yeah, this one we initially thought the same way.
Yeah. But the tubing was short, na? That's why it
length नहीं
initially it was supposed to do that way only.
So you only need one tubing only.
One tubing.
And one tubing and one wire connector, nothing else.
Nothing else, right?
Don't hurry into especially connection. Whenever you hurry into connection, this will split. Just you have to plan it before, like just take 5 seconds of time.
No need to prime. Is it connecting
You
now?
need to prime.
Just before connecting, you can prime the whole thing at a time. You are priming this again,
Oh,
you
yeah,
prime
yeah,
that
correct,
connection
correct.
again, this connection again.
Correct, yeah.
Both will get primed.
And when you are struggling with air in the circuit, right?
Yeah.
So always keep both the ends like this and then connect it like
Yeah.
this. You are connecting like this, so whatever the saline is there, it is going to.
Falling now.
So this is the right connection.
क्लैम्प खोल दे अंदर का अंदर का खोल दे खोल दे. So what is happening is the most of the flow goes to the vein because there is a less resistance. The arterial flow is not there. So what you have to do is you have to partially clamp the
arterial
vein.
side.
Okay.
Or no, venous side.
Fine.
In real scenario, it don't take more than 30 seconds to connect it.
So put a return cannula and keep the tube primed. Okay.
It is not taking.
Correct, sir.
So like this main circuit was there. It was attached.
तो 1 घंटा लग जाएगा.
Yes. Okay, that becomes so fast. Yeah.
Now, if you still have doubt, you want to make it much more faster, no? As you said, you have taken a 3-way.
Yes.
You'll have 3 tubings for that.
Yeah.
You clamp on the return line.
Yes.
This will be clamped for the 3-way, 3 tubings.
Yes.
These 2 ends will go, the tubings will go into the VV. So you are technically converting VA to VV with a clamp already here on this.
Yes.
So you'll have some time. That is
Okay.
done. Once that is very much cool,
Then you make it.
come back to the artery here. You can connect it here and remove the clamp.
So we.
It also can be done. Your ultimate end is VAV only. To cut down the time, first you prime the bridge, everything. 3-way with 3 tubings, you prime all the things together. Okay. 3-way has a straight and T. The straight goes into the venous return.
It becomes
So
easy.
it will be VV again.
Yeah.
The T which is there, which goes to artery, that you can do it in a slow way.
Later, sir.
Because you don't have an urgency.
Yeah.
Because VV is already established. You can cut down the time also. That also can. But that bridge should be primed, kept ready. That time and all patient will be on already VA. So you don't have much complication. Clamp, cut it off directly, connect the straight limb of the T. So VV is on. You open it off. This clamp is still there on the T end.
We can open it.
That you can come to the artery. Then slowly you can. So you
Again,
can
if the VA flow is high, then
the flows are a later thing. I'm just telling this to cut down their connections and more safer. So VA से VV हो गया. Within seconds से you can connect to VAV. So that's the that's the plan. Clamp time should be.
So do we have to increase the anticoagulation once they go on VAV?
Yeah. No, you keep it around 180 to 200 because that's fine.
already on VA,
You are copying 180 to 200, so that's fine. One more question now. While patient is on VA ECMO and you want to convert to VAV ECMO, what is the, while cannulating, what is the complication you expect and you have to take care of?
Air embolism.
When you are cantiling, yeah, air embolism. That's the most important. So when you take a puncture, okay, before you put a wire, when you disconnect the syringe and put a wire, you have to clamp the circuit so that there should not be negative pressures. Okay, because your cannula in VA ECMO is going to be in RA, drainage cannula, so it will suck the air. Okay, and the air will get sucked. So for just transient seconds, you have to just clamp that so that you can put the wire inside. Once the wire is inside, then you are not worried. Okay, and then gradual dilator. Same thing when you are removing the dilator. Okay, so your cannula is going to get exposed, isn't it? And then it can get exposed directly to the, and it can get suck massive air inside. So again, that time you have to clamp it for a few seconds. Okay, might be 5 seconds or something less than that.
We have to clamp venous and arterial, sir, only venous. We have to clamp only venous cannula, both venous and arterial. Only drainage cannula.
Yes.
Drainage cannula.
Anything more? Anybody's there in the audience or nobody's there? Nobody's there. If there's anybody in the audience, if they have any questions, they can ask us. Fine. You have any questions?
No, no.
This, how to then
Okay.
target?
Now, coming back now, is there a clarity in your mind now that you are still confused?
I think I have a clarity. So I will never go for a VV ECMO directly from a VA. Go for VAV and then gradually come to a VV ECMO. That's it.
Okay, fine.
That I was going to tell.
Yeah. So now you tell, there are so many things we talked, isn't it?
Yes. Yes. For differential saturation, we need to have arterial cannula, extravenous cannula. That is the only way in which the patient can be dealt off.
Not the only way. Again, if
After giving
yes,
medical management.
yes, if that fails, then that is the only way you can get out of it. Yeah.
Call for help when you don't know. what
Yeah,
to do.
that's always better. Rather than just taking us, just taking a simple path, better to involve someone who knows it and call for a help. Okay, fine. That's a good point. Yes.
We need to set limits or set criteria whenever you want to step up or step down from a particular kind
Yeah.
of technique.
Then you should have clarity of. As in the previous batch also we talked about that. Okay? You should have that some figures in your mind. Okay? This is going to be acceptable figure. This is going to be not acceptable figure. So that is going to be an important point.
Have a perfusionist standby to connect the things if we are not able to connect.
Yes, she said that. Call for a help. Something else. And that's
Divide
what
into
is
teams
required in
such that
ECMO.
one will take care of the patient while doing the things.
Yeah, so take care of someone has to take care of patient. You are all into that. The patient had a bradycardia,
Bradycardia.
hypotension that you could not notice it. So always, whenever there is something wrong goes with the patient, you have to divide yourself two teams. One team is going to take care of the ECMO and one team is going to take care of the patient. Okay.
Don't leave the arterial cannulas unattended. It clots, so make sure that somebody.
Yes. Don't keep any ECMO cannulas unattended. Okay. Venous or arterial. Arterial never. Venous you can still flush, but arterial is going to be difficult here.
Initiation, changing the mode, and weaning should all be meticulously planned with a set objective criteria. That's like subjective criteria don't help. Objective criteria and then only.
Yeah, so you should have your the way you should have checklist. You should have points. That this is the numbers you are going to follow, and you will act at this number. You are going to act like this. So you should have set protocols designed for everything. Yes.
Sir, while weaning, at least check the LV function with a minimum 1 liter of flow.
Yes.
Weaning the VA ECMO.
Yeah. So
minimum 1 liter.
Yeah. So you have to just always go for an ideal flow. Its ideal flow is, I said, 20 ml per kg. So depends on the, if it's pediatric, again, that is going to be not 1 liter, but that is going to be, say, 500 ml or 600 ml, whatever the flow is. That you should go for an ideal flow, where there's the minimum work the LV has to do it, the LVs get relaxed with, so that you can.
Circuit, yes.
So if you want to master ECMO, you should know how to play with the circuit. So that is important. Anything you want to add,
Prerequisites for VAV?
Madan?
What are the basic two prerequisites for a VAV? From VA to VAV, or two prerequisites for developing a north-south syndrome? Other way. There should be two things that should be there for a north-south syndrome to develop. What are the two things?
One is improving
Good RV,
Improving,
good LV
improving
function.
LV and worsening lung.
That is understood, then you'll understand the whole physiology. And Pranay sir, after attending this conference, if they say call for help is what I learned, is it a success or a failure? I'm asking you.
No, I'll still feel it's a success. I'll tell you the reason. I still... No, I still call up Madan a number of times, isn't it? Yeah. Yes. Yes.
Know your limits.
So ECMO is such a vast, and the number of cases what we are going to see is such a small number, that's very difficult for anybody to get mastery in ECMO. You know, I don't think anybody will come and say that, okay, I have done 1,000 ECMO cases. Okay, many of us will say, I have managed 1,000 ventilator patients, but I don't think hardly people will be able to say that, okay, I have done 1,000 ECMO cases. They will not manage. Scene is different, managing is different. So that's the basic reason is because you will may not able to get the whole spectrum of ECMO complications in your lifetime. So then you have to be rely on someone who has seen more than you. So always call for help is not a bad thing. Whenever you are confused, better to call for help rather than getting messed up in anything. Thank you.
Thank you very much.